Welcome back to Teach Me in 10, a video series brought to you by Technology Networks. Here we invite scientists to discuss their research or a scientific topic in less than 10 minutes. My name is Rihanna Lilly and I'm an editorial assistant for Technology Networks. Our guest here today is Professor Sir Peter Donnelly, an emeritus professor of statistical science at the University of Oxford and founder and CEO of Genomics plc. Today, Peter is going to teach us about polygenic risk scores and how the possibility of a single test measuring susceptibility to many common diseases simultaneously opens up the possibility of true prevention healthcare.
Until a few years ago, if we knew the entire DNA sequence of a healthy 40-year-old, we'd learn something medically actionable in about only 1 or 2% of cases. And that's because genetics has played into medicine very effectively by focusing on conditions caused by single changes in our DNA that affect a particular gene and cause serious conditions. So think cystic fibrosis or Huntington's disease as examples. Now it's the case that if I have DNA information on a healthy 40-year-old, I'll learn something medically actionable in about 70% of cases. So from 1 or 2% a few years ago to 70%, that change happens because we can now measure the genetic part of risk for all of the common diseases, for heart disease, for diabetes, for common cancers like breast cancer and prostate cancer and bowel cancer, the conditions which cause most of the sickness in our populations and use most of our healthcare budgets. And that change is driven by polygenic risk scores. So it turns out that for any one of those common diseases, like heart disease, there's not one gene that matters for heart disease. There are 2 genes that matters. There are more than 1 million places in our DNA, each of which has an impact on our risk of developing heart disease. We've now done large enough studies to identify what are the positions which matter for heart disease, and there'll be a different set of 1 million or more positions which matter for diabetes and another set for breast cancer and so on. And furthermore, we have algorithms that combine the information from those positions effectively to give a single overall summary of a person's genetic risk for a specific disease, say heart disease. And that single overall summary is called the polygenic risk score. The figure on the slide shows the impact of the polygenic risk score in heart disease. This is data in men who have a higher baseline rate of heart disease than women. It's data from 100,000 men studied prospectively forward in time in UK Biobank. And these men are independent of the ones used to train the algorithms to derive the polygenic risk score. And what the plot shows is for 3 different groups of men defined by their polygenic risk score, what proportion of each group have developed heart disease by a given age. The red curve are the men whose polygenic risk score is highest, so in the top 3% of the distribution of scores. The green curve are those in the middle of the distribution, and the blue curve are those at the low end of the distribution with the lowest genetic risk for heart disease. And the differences are pretty striking. So for a man in the high risk group, by the time they're about 75, their chance of developing heart disease is around 40%. In stark contrast, for men in the low risk group at the same age, their chance of developing heart disease is 2 or 3%. So really big differences in disease outcomes depending on this polygenic risk score. And similarly for men in the high risk group, a typical man in that group by his mid-40s has the same risk as the average risk in the population at about 65. So risk accrues much earlier in life. That's a figure for heart disease. There are polygenic risk scores, different polygenic risk scores for different diseases. On the left, I'm plotting breast cancer. On the right, prostate cancer. All of these figures are in individuals with European ancestries. And again, very big differences in disease outcomes or the proportion of each group who develop disease depending on polygenic risk. Big separations between disease outcomes in the high risk and the low risk groups, on the left for breast cancer, on the right for prostate cancer. It's worth saying that for all of the common diseases, genetics is a major risk factor. For some of them, it's the single most important risk factor. And for some, it actually dwarfs many other risk factors. So just briefly in the figure on the right, each row here is a known risk factor for a woman for breast cancer. The length of the bar and the The number next to it is a measure of how predictive that risk factor is by itself. The third bar from the top combines many of the known risk factors for breast cancer, including family history and mutations in things like the BRCA genes. The second bar from the top is just the polygenic risk score, and it's already more predictive than all the other risk factors put together. And indeed, if you add in all the other risk factors, you only improve predictive power by a tiny amount. Here's another diagram which shows on the left disease outcomes for type 2 diabetes, depending on the polygenic risk score for diabetes, in European ancestry individuals and South Asian ancestry individuals, where the baseline rates of diabetes are higher. This is all UK data. And what you see is even larger separation and higher rates in the high-risk individuals in South Asian groups. There's a live issue with polygenic risk scores and different population groups. They tend to be most powerful in European ancestry groups. We and others are working both on methods that decrease those differences in predictive power, and also on getting more data from groups that have been underrepresented in genetic studies to date. Nonetheless, it's the case that for many or most common diseases, polygenic risk scores provide useful information in all ancestry groups. This is another condition, obesity. I think very striking data. This is an analysis we did within, as the ones above, within our company Genomics PLC, of a study in the UK called ALSPAC. It studied around 10,000 people from birth in 1990 forward through time. And what's plotted here is the BMI. So that's a function of your weight and your height for the kids in the ALSPAC study at different ages, 8 months, 3 years, 8 years, and 18 years. Each point is the average of a group of kids, and the kids are defined by the groups are defined by the kids' polygenic risk score for BMI, for high BMI, so that the first dot in each plot are the ones with the lowest polygenic risk scores, the lowest 10%, the next 10%, and so on, up to these who have the highest risk for BMI from genetics. And even at 8 months old, you can see a relationship between the genetics and the actual BMI. It's more marked at 3.5 years, and it's incredibly striking from 8 years and 18 years. So as an aside, it's impossible to look at this data and not realize that genetics is an incredibly important part of the story of obesity. In fact, recent studies have shown that it's more important relatively than lifestyle factors. Of course, they are important as well. This is a summary for a range of different diseases of how much more likely someone in the top of the polygenic risk distribution is to develop the disease compared to someone at the better end of polygenic risk. So I showed you data earlier for prostate cancer, for heart disease, where it was about a 20-fold difference in risk. For prostate cancer, it was bigger. It turned out to be 40-fold. For diabetes and atrial fibrillation, it's almost 30-fold. For breast and bowel cancer, it's about 10 to 15-fold. So really big differences in risk and in outcomes, depending on polygenic risk scores. To give you a sense of where this might be used, I'll talk about some of the work we've done within Genomics PLC. This is a major focus for us in the company. Earlier, it was a major focus of me as an academic. So we did a trial in the UK with the National Health Service to look at adding the genetic component of risk into cardiovascular risk prediction. So cardiovascular disease is heart disease and stroke. Primary care physicians, who are called GPs in the UK, routinely estimate a patient's risk of cardiovascular disease using a clinical tool, which happens to be called QRisk in the UK. It's similar tools are used in other countries with different names. And those clinical tools combine information about a person's age, their sex, their blood pressure, their BMI, their cholesterol level, family history, smoking history, and so on. And they estimate a 10-year risk of disease. And based on that, the doctor will give advice to the individual, potentially about medication like statins, and also about lifestyle changes. The genetic component of risk, measured by a polygenic risk score, is independent of that clinical risk factor. And so it can be added to it. And it's substantial. For a man between 45 and 55, the genetic component, the polygenic risk score by itself, captures as much of the risk as does the clinical risk tool. So in our trial, we showed that this could be added into clinical workflows effectively. It was very popular with patients. 98.5% of them found it very helpful. And in 13% of cases, the doctors changed the management of the patient because of the extra information. And this figure shows the 10-year risk just based on the clinical tool and then when genetics is added in. And finally, I'll mention the number of large-scale programs. In the UK, there's a flagship program called Our Future Health that will recruit 5 million individuals over about the next 5 years. The key part of that is giving those individuals information about their disease risk based on genetics. We're delighted to be the company that's supplying those risk tools to the Our Future Health program. So within 2 or 3 years, there'll be millions of people in the UK who understand their risk for some diseases better because of genetics. We're also working, as are others, with programs and health systems in the US and other countries. I think this changes the way we can think about genetics and changes the way we can think about prevention and healthcare. Each of us will be at high risk for some disease. We just don't know what it is. And this approach allows individuals and their doctors to know in advance what they're at risk of so that we can do a much better job of making changes as individuals, but critically, getting people into the right screening programs, the right treatment programs, and the right prevention programs at the right time. Thanks very much.
Thank you for joining us here at Teach Me in 10. If you'd like to learn more about polygenic risk scores or Professor Sir Peter Donnelly's work, make sure you check out the resources linked in the video description. Stay tuned for our next installment of Teach Me in 10.